to the meeting host co-host. And if you have a supporting resource link to share with meeting participants regarding an agenda item currently being discussed, please share that link with the meeting host or co-host in the chat, and they'll share it with all meeting attendees. And materials for today's meeting are available on the Oregon Health Policy Board website and are hyperlinked in the meeting agenda. Tara is always so good at putting links and repeating important key information in the chat. Really appreciate that. So with that, are we ready to do attendance roll call?
Yeah, let's go ahead and do it. I see members are still joining us, but we still have several here. All right, I'll start with Tony German.
Present.
Brenda Johnson.
Present.
Bill Kramer.
Present.
Hayden Rook Lee.
Present.
Melina Moran.
Present.
Kirsten Isaacson.
Present.
Dr. Hemmings.
Here.
Great. Peter Starkey. One more time for Peter Starkey. All right, I'll check with Peter, make sure he's on his way. And Aaron Hines. All right, looks like we, for current active members, we have 7 of 8 members present for quorum.
Excellent. And I just want to flag, folks may have noticed a new name at the end of the list there, Aaron Hines. When Aaron joins us, we will take a moment, have him do his introduction of our newest board member. And I guess while I'm at it, I'll say that Aaron was confirmed by the Senate. He'll be officially joining the board in January. But it's great to have them with us in the meantime. You may notice that as we do our voting roll call, Aaron will not be voting until the new year. But happy to have them join. Okay, so with that, we'll keep rolling with our meeting. And Tara, if you just want to flag, I'll try to keep an eye out too, but if you flag for me when Aaron joins us, we'll find a break and do an introduction. This month's health equity reading will be done by Melina Moran. Melina, turning it over to you.
Thank you. Good morning, everyone. And thank you for allowing me to read this and remind us to center this meeting around equity. Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determinate circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. Thank you.
Thank you, Melina. And thank you for giving us this wonderful tradition, Brenda. I acknowledge that. Okay, so Aaron has arrived. So before we move into some of our housekeeping items, let's hear from Aaron. Aaron, I'd like to welcome you as our newest Oregon Health Policy Board member. Would love to take a minute to hear from you.
Hi, Kristen. Aaron is in the queue still trying to join the meeting, so I think I was a little bit premature to say he's in the meeting, but it looks like he's having some technical issues and we'll be here in a moment. So we could go ahead and go to the minutes and then back to Aaron.
Yeah, we'll keep rolling. Thanks. Okay, conflict of interest. Before we begin today's meeting, I want to remind all board members of our obligation to disclose any actual or potential conflicts of interest. So after you review today's agenda, if you have a financial interest, professional affiliation, or other relationship that could be reasonably perceived as influencing your decisions or participation in today's discussion, take a moment and share it for the record. As a reminder, you should share actual or potential conflicts of interest. If in doubt, share it. And your transparency helps ensure the integrity of our work and maintains public trust. So are there any members who would like to share an actual or potential conflict of interest at this time related to today's agenda? Go ahead, Brenda.
Thanks. I know today we'll be talking about the Healthcare Provider Incentive Program. And while I don't have a personal direct conflict of interest, I lead an organization that employs providers that benefit from the Provider Incentive Program. So I want to recuse myself from today's vote and let everyone know that's why. Thank you.
I also have something to disclose is that I may be part of the provider incentive program. So I will not be voting.
Hi, this is Dr. Hemmings. I may also be potentially impacted by that issue, so I will not be voting as well.
Okay, thank you, board members. Tara.
Yeah, thank you all for disclosing and sharing that. So with 3 sitting out, we will have 5 active members available to vote. And so we will need all of their yeses in order to pass any business today.
Okay, good to know. Well, with that, our first order of business this morning is to vote on the September and October Health Policy Board meeting minutes, just because we didn't vote on any minutes at our retreat. So the draft meeting minutes are included in today's meeting packet as attachment 1 and 1.1. And is there a motion to approve the draft OHPB meeting minutes from September and October?
This is Brenda, so moved.
Tony German, second.
Thank you, Brenda. Thank you, Tony. All those in favor of approving the September and October board meeting minutes, say aye. Or give
Aye.
a thumbs up.
Aye.
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 Are there any opposed? Any abstained? All right, the minutes are approved. Okay. As chair and vice chair, well, I'll do a little OHPB business updates. But as chair and vice chair, Tony and I meet monthly with the governor's office and OHA leadership. And in our last meeting, we discussed the governor's focus and efforts to develop recommendations to help preserve the Oregon Health Plan in light of the budget reconciliation bill passed by Congress, HR 1. This came out of our retreat as one of the requests that we specifically bring this up. And so wanted to share what we learned. Really co-leading this effort is Christina Narayan, our governor's office health policy specialist, and Bruce Goldberg. And so once there are substantial updates to share from that governor office led process, Christina says she'll share those with us at a future OHPB meeting. Oh, okay. And there were a couple other items in our retreat follow-up. At the retreat, we agreed to compose 2 letters, one to the Metrics and Scoring Committee members and staff, and the second to the Behavioral Health Division. So the metrics letter was finalized, and the behavioral health finalized and will be delivered, and the behavioral health letter will be shared with OHA this week. And some of the other retreat follow-up items, including updates from the affordability and primary care priority work groups, are scheduled today in today's meeting. I also forgot to add that we talked about sharing our CCO procurement report, and we did share that with the governor's office, thinking about this table that Christina Narayan and Bruce Goldberg are leading to inform that. And apparently I forgot to go over the agenda, just skipping all over. So do that fast. Sorry, everyone. I'm in a different space and apparently can't get my act together. Today's agenda, we'll have welcome and roll call, which we did. We have a few more items of business that we'll cover. And then we will hear an update from the Behavioral Health Division. And then the Healthcare Provider Incentive Program administrative cost presentation. We'll have public comment. Then we'll have our OHA and OHPB updates conversation collaboration. That's the one that's usually at the top of our meeting. We're just doing it later today. And then we'll have our retreat follow-up around affordability and primary care. And then we'll have closing comments and adjourn. So with that, we will move to our OHPB new members. We did have a recent Senate confirmation of our 2 newest members, and we'll turn to one of them shortly to introduce himself. But with that, we still have 1 vacant seat available on the Health Policy Board. And so I really wanted to flag for everyone attending today's meeting, if you're interested in becoming an Oregon Health Policy Board or know someone who would be interested, please review the membership application and apply through Workday. Tara will put those links in the chat and they're on our website. And so with that, I would like to turn to one of our newest board members, Erin. Would you like to introduce yourself, please?
Good morning. Can you hear me?
Good morning. We can hear you.
All right. Well, good morning, everybody. My name is Aaron Hines, and as it was noted, I was recently appointed, but I won't be officially seated until January. But I'll jump in on these meetings today and next month and try to keep up on all the issues that we're discussing. But I'm the Chief Executive Officer for the Yellow Hawk Tribal Health Center, which is owned and operated by the Confederated Tribes of the Umatilla Indian Reservation out here in Eastern Oregon. And I've served in various capacities for the tribe, and I've worked with the state in various capacities. So this is just another opportunity that I look forward to working with this board and seeing what we can do to advance and improve the delivery of healthcare to all Oregonians.
Excellent. We look forward to joining you on that path, Erin. So thrilled to have you here and to work alongside you.
Thank you.
All right. The Oregon Health Policy Board is not the only entity seeking new members. I do want to highlight that the Industry Advisory Committee on the Healthcare Affordability Committee is actively recruiting for new members. So they're seeking industry expertise that's not currently represented on the committee, specifically focusing on dental providers, behavioral health specialists, traditional health workers, and insurance brokers. So applications will be due mid-December with the goal of appointing new committee members in January. And the purpose of the Industry Advisory Committee is to help identify cost-saving solutions, address policy implementation challenges, and shape policies that drive meaningful change. So for more information, you could see there's a website that Tara will put in the chat, or also an email to contact if you have any questions. And with that, we will move to our first presentation and update from the Behavioral Health Division. We have their leadership team with us to present updates on behavioral health metrics. So I'd like to welcome Ebony, John, and Maria to the Behavioral Health Division leadership team to the Oregon Health Policy Board meeting. We'll put your slides are up, and you can begin whenever you're ready.
All right, thank you very much. And this is John Collins. I'm a Deputy Director in the Behavioral Health Division in charge of operations and strategy. Ebony is unfortunately not able to join us this morning due to some issues that came up. So you have myself as well as Maria Williams. Maria, can you introduce yourself real quick?
Sure. Good morning, everyone. My name is Mireya Williams, she, her, ella, and I am a Behavioral Health Metrics and Committee Manager. And myself and my team support the work of the Behavioral Health Committee. Thank you.
Thanks. Next slide, please. So today we want to give you guys a quick overview of the OHA strategic plan structure and the terminology that we're using to describe the work. We'll provide an overview of the OHA strategic plan, and specifically the transforming behavioral health pillar work that the Behavioral Health Division is supporting, and the remaining efforts for the 2025 year. And then Maria will give you an overview of some of the work that's going on with the Behavioral Health Committee. Next slide. And then the next one. So I imagine you all have seen this particular graphic a few times before. A quick reminder about the term key performance indicators. This term has been used previously in the space, but we want to steer away from that term and start using the term measure instead. The Behavioral Health Division as a division and the OHA strategic plan do not have key performance indicators. We're using measures to show and measure change over time. The OHA strategic plan is rooted in the health equity definition and is meant to align with the OHA goal of eliminating health inequities by 2030. There are 5 pillars, as you can see, and they're identified as the crucial work in order for us to achieve that 2030 goal. And again, I'm assuming y'all have gone over these pillars before, so I will not review each one of them. The Behavioral Health Division's focus, as you might imagine, is on the transforming behavioral health pillar. The OHA strategic plan is rooted in the health equity definition, as we've already said that part. But let's go on to the next slide. Sorry. So basically, there are 3 sets of measures that we're tracking. There's the global measures. These measures are meant to holistically be representative of behavioral health efforts in Oregon. They're very high level, and in some cases, in all cases, actually, they're not necessarily things that the Behavioral Health Division or even OHA can impact on its own, and requires work across all the various agencies and public out there to actually have an impact on some of those measures. Then we have outcome measures that are tied to the pillar strategies and show improvement at each one of those strategy levels. And then process measures, which are tied to the pillars and the strategies and the actions associated with those strategies. Next slide, please. So this is a little bit clearer illustration of what I just talked about. The Transforming Behavioral Health pillar has 5 guiding strategies. Each strategy has 1 outcome measure tied to it as an indicator that efforts are having a positive impact on the behavioral health system and those accessing the services and care. Another way to think of this is strategy equals an outcome measure. And the outcome measures and their data can be viewed on the public dashboard that went live back in January of this year. Each strategy has actions that describe specific efforts or work being done to help us reach that strategy goal. The Transforming Behavioral Health pillar strategies have 3 actions each, and each action will have at least 1 process measure so that we can determine how our actions are supporting the strategy. Another way of thinking about action is as a process measure, which makes sense. Next slide. So we are still building this all out, and this slide is really meant to give you a high-level overview of where things currently stand. The global measures were selected by the OHA director, Dr. Sajal Hathi, and put forward in November of 2024. And again, they're part of that public dashboard that you can check out. The data for the public dashboard was submitted for inclusion back in December of 2024. The strategy outcome measures have also been completed, and they were submitted also back in December and approved on the same date as the high-level measures, the global measures. And we anticipate reporting on year one improvements associated with the goals in the first quarter of 2026 as data becomes available and gets published and approved for publishing on that dashboard. We are still in progress on a couple aspects of this, the action measures and the strategy outcome measures for year one improvement goals, but these should be completed shortly. Let me go to the next slide, please. As you, I'm sure, are aware, as time passes, there are lots of things that come up that weren't part of the original consideration in this type of process. We are trying to pivot to ensure alignment with OHA's federal response team as they put together the strategies that we're compiling as the perspective from at the federal level changes and puts forth new expectations of us. And that ends up impacting some of our data collection and data definition. So in other words, an example of that is that some of our global measures in particular relied on data sets that came from the federal level. And in some cases, those might not be updated as frequently or maybe changed compared to what we had expected when we initially put them together. So we might need to make some changes to those based on that. We need to ensure the equity impact assessment is done to minimize harm in our measure selection. So if we make changes, that would be something we would also want to reapply and consider. And I am sure in these days and times that there are other changes that will be on the way for us, and we will obviously need to be flexible and accommodate those as needed. So I know that's a very high level, just descriptive understanding of what we've done for the behavioral health transformation pillar without really going into any of the content. But I'm sure in the future, particularly as we start getting some data associated with some of those measures, that we can bring that forward and talk about it. I'm going to hand it off now. Let's go to the next slide to Maria so that she can give you an update on the Behavioral Health Committee.
Thank you, John. Okay, next slide, please. Thank you. So just want to provide a refocus of our goal for the Behavioral Health Committee as established through House Bill 2086. The Behavioral Health Committee is to assist with establishing quality metrics for behavioral health services provided by coordinated care organizations, healthcare providers, counties, and other government entities. And it is also assisting with establishing incentives to improve the quality of behavioral health services. We are tasked with also designing these incentives and metrics with improving the integration of physical and behavioral health care, improving timely access to behavioral health care, ensuring individuals are supported in the least restrictive environment that meets their behavioral health care needs, and also reduce hospitalizations and reduce overdoses. So those 5 areas are the areas of priority that we focus to ensure that these measures and incentives are designed with those elements in mind. Next slide, please. So I want to share with you what we have done through 2025. This has definitely been a learning journey and experience for our members. You know, metrics are not something that are done overnight, so it does take some years of development. But before we get to the development, there's learning of what we know, what we don't know, what exists and what doesn't exist, and where are the gaps within our systems and services. So we began with exploring and learning about the screening benefit intervention referral to treatment, which is the SBIRT. So the committee learned about where it is used and the purpose and the history of that as a consideration for them to think about if this is something that they may want to explore in the future. We also learned, or the committee was provided with learning opportunities about understanding the difference between an upstream metric and a downstream metric. We also were informed about some changes to Senate Bill 966 that also impact some of the measures that we would be exploring moving forward. We also looked at downstream measures, a downstream measure menu for the Centers for Medicare and Medicaid Services, and we did a crosswalk with our priorities to the CMS core set for the behavioral health measures and our 5 legislative priorities. And members also learned that in 2025, the Metrics and Scoring Committee selected 13 quality incentive program metrics, 5 of which were upstream and 8 were downstream metrics, which 3 out of the 13 quality incentive program metrics in the behavioral health domain, that's what was in the behavioral health domain. So 3 out of the 13 quality incentive metrics within the program were behavioral health, in the behavioral health domain, excuse me. So the Behavioral Health Committee also explored recommendations and we posed questions regarding, do the 2025 Metrics and Scoring Committee behavioral health measures feel represented to you or the committee and focused on the 5 legislative priority areas? So that was a question that we explored, or the Behavioral Health Committee explored, to think about what recommendations they want to provide moving forward. And the other question is around, are there other CMS behavioral health measures that might bolster work in the 5 legislative priority areas if they were added to the metrics and scoring list in 2026? So we did some exploration and some learning around those questions with the members. Excuse me. And the members also learned about what recommendations, the risks and the benefits and the timeline associated with providing recommendations. As I mentioned, we looked at the 5 legislative priorities and compared them to the 2026 CMS core set for behavioral health measures and did a crosswalk. And looking at, where are the 5 goals most represented in the behavioral health measure set. And so in March, we participated in just reviewing the timeline, selecting measures and reviewing timelines, some options and preliminary rankings that the committee explored. In April, so quarter number 2, the committee provided some recommendations around their interest for what they wanted to provide for, recommendations into the quality incentive program measures set for 2026. And so the committee came up with, wanted to support the continuation of 2 existing measures, and also wanted to, the Metrics and Scoring Committee, to consider additional new metrics, which were follow-up after emergency department visit for mental illness, ages 6 to 17, and follow-up after emergency department visit for substance use, ages 13 to 17, and also 18 and older, and for mental health, 18 and older as well. So the mental health lifespan essentially from emergency department visit, and then the lifespan for the substance use disorder follow-up after emergency department visit as well. In May, the Behavioral Health Committee voted on these recommendations and finalized the recommendations to share with metrics and scoring during their June meeting. We also learned about the Behavioral Health Resource Network program. We had a presentation in May after we voted for these recommendations. We learned about what was happening with the Behavioral Health Resource Networks, which is another element or area that the Behavioral Health Committee is working, a program they're working with in identifying what could be opportunities for the Behavioral Health Committee to provide in the recommendations for data in the future for the Behavioral Health Resource Networks. So that was Q2. We did share, or our chair did attend the meeting for metrics and scoring in June and presented the recommendations. And in July, Q3, we learned about the recommendations that were accepted and the recommendations that were not accepted by metrics and scoring. And we learned some valuable lessons along the way of what we could do differently and where we can ensure that we are providing the recommendations timely to metrics and scoring, so possibly earlier than June. So maybe January, February is the timeframe that we're looking for in 2026. And we also learned that it would have been beneficial for the committee to perhaps prioritize their recommendations. So that was something that we walked away with and that we're hoping to plan moving forward for our journey in 2026 to provide recommendations for the 2027 quality incentive program measures. So in Q3, we also received an update regarding the county financial assistance agreements, which is another area that the Behavioral Health Committee is interested in assisting with providing, future recommendations for the county financial assistance agreements. And so we got some updates with regards to where that's at in the process and what we can hopefully get updates for in the future once those agreements are signed at the end of close to the end of the year. And we had an update for CCO procurement as well as another body of the Behavioral Health Committee's work, just to learn about what is happening in the CCO environment and where the Behavioral Health Committee may be able to provide recommendations for the 2029 CCO procurement. If we start our planning now, that we can inform a greater impact by that time, or inform and have time for the learning and finding where the gaps are to inform the CCO procurement for 2029. And the last quarter, so we are still in the last quarter, but we had a presentation from our partners with the Health Policy and Analytics, and learned, reviewed the CCO quality incentive program and what we can do to prepare to provide recommendations for 2027 measure year. If the Behavioral Health Committee would like to consider exploring that for 2027, providing incentive recommendations for 2027. So that is what we have accomplished for 2025, and we hope to paint the pathway similar in 2026 with a little bit tighter timelines and more specific sharing of information with you all in terms of where the committee is and what recommendations they're wanting to provide and how you may be able to support those moving forward. Next slide, please. And then just wanted to share with you all, the deliverables that we were tasked with. And ultimately, it's the contracts between OHA and coordinated care organizations or individual providers of behavioral health services must align with the quality incentives and metrics delivered by the Behavioral Health Committee under ORS 413.017 and contain provisions that ensure that individuals have access to needed care. Services are responsive to individuals and community needs. Services will lead to meaningful improvement in individuals' lives. And once we have accomplished or identified metrics, the committee will explore incentives and other system changes that may be needed in the future. And over time, the committee will review OHA performance to ensure metrics, incentives, and system investments continue to align with impact key outcomes. Next slide, please. Excuse me. And lastly, this is where, the key areas where the Behavioral Health Committee needs the Oregon Health Policy Board support. And so, as I mentioned, the committee is in the process of exploring providing behavioral health measure recommendations to the Quality Incentive Program for measure year 2027 and potentially beyond. But right now, we'll start with 2027. And also your support in recommendations that are made for the 2029 CCO procurement. Oftentimes we don't have time to plan and we move at the speed of light. And unfortunately, when we do that, we impact communities in a negative way. And this provides us with that intentionality to ensure that we are recognizing, reconciling, and rectifying contemporary and historical injustices and how we are redistributing and distributing the power and resources, and hoping that we can embed those in our process and journey of development. And that is all I have for you all. Thank you so much. Do you have any questions?
Thank you. I'm sure the board does have questions, and we have about 12 minutes for those. And Maria, thank you for the intentionality, and certainly there is some time to prepare for that CCO next procurement. So appreciate the engagement and using that time wisely. John, I was wondering, I think it was over a year ago that the Behavioral Health Division came before this board, and we're very interested about behavioral health, for the same reason that I think both of you share an intense passion for. There is a need, and people, we have like a duty to Oregonians, and we all desire to improve services and make sure people have access to what they need and are getting it. And so with that passion, I think Behavioral Health Division came forward and gave a presentation and basically asked the boards and said, hey, we have these, we'll call them measurements. We have these measurements, and we'd like to be held accountable to meeting the plan laid out and these measurements. And so I was expecting information today about progress of those measurements, including data. I hear you reference that it's on the dashboard, and that the action process measures are not set yet. But I guess I'm feeling a disconnect between what the board was asked to partner with the Behavioral Health Division on a year ago and today.
Thanks. Well, I think it's probably mostly a timing issue. As I mentioned, a lot of these measures and and updates, and in a couple of cases, first-time publications of them will go onto the dashboard, which, as I mentioned, will come out first quarter of next year, along with the measures and for all the other pillars that are associated with the OHA strategic plan. I think at that point in time, that'll be our best spot to actually go over the data and discuss, how we're reacting to it, what your thoughts might be in terms of addressing deficiencies that might be showing up. So that's kind of where we are. We didn't want to get out ahead of the rest of the pillars in terms of that part of the process.
Are there board members who have comments or questions? Tony, go ahead.
Yeah, thank you both very much in the presentation. Help to kind of walk through and clarity on definitions and looking on the measures. John, yeah, I a question actually regarding with the Behavioral Health Committee and the quality incentive. There's a lot of, I think, some overlap in the strategic plan for the state, but then another tool with the Health Committee, in utilizing a few of those measures. My question is, for our Behavioral Health Committee and leveraging a value-based approach to incentivize health systems to get follow-up for depression screening and substance use post-ER. Those are the measures that we have chosen there. There's a lot of discussion around the concern of what those dollars will look like. And then I think it's important for us just to be aware of where that body of work is taking place. And I wonder if you could help me. My question is most of that quality incentive is directed at the CCOs, and is a body of that work in the primary care network, or what are some of the CCOs doing to help bolster up that work, and how are we measuring that? And that would be something I'd like to see further when we come back, those reports, to see what are our interventions doing, which I think there is some overlap in the strategic plan. But then in those specific targets for follow-up for depression and for substance use for the youth, where is that body of work taking place? And is that mainly in the primary care in a capitated model for our healthcare systems, or is that our more expansive network of behavioral health colleagues?
Maria, I'm not sure if that directly overlaps. Is Derek on the line? And I'm wondering, Maria, certainly answer whatever you have, but I'm thinking that Derek Renke might have a response to that as well.
We could put a pin in it.
Okay.
I know it may not fall directly in your guys' purview, but my question is actually a little bit, we've been focusing in on where bodies of work take place in the state. And I would just make the observation that a lot of the metrics have fallen on primary care in the state. And the observation is that we ask a lot of people to do a great deal of work, but then the means of communication from an ER to a primary care setting or health center or other hospital system is that we put in place these expectations to meet these marks, but then the ability to have that direct line of communication. For instance, in a primary care network, whether I get an ER report on a kiddo that was seen or substance use, there's sometimes a disconnect. And also the great deal of work that I have for a group of individuals to do the recall efforts and all of that. So it's just something that I think we need to continue to pay attention as a state when we're thinking about quality incentive payments being potentially pulled back, of what we focus within our own behavioral health committee, of the expectations for quality metrics and quality payments. And so that's really just my focal point with this question.
Gotcha. Appreciate that, Tony.
Bill, go ahead.
Thanks, John and Maria, for this presentation. I have two comments. First is maybe a picky thing, but I want to make sure we get this right. On slide 5, I like the categorization of the measures, but one comment is the global measures are described as holistically representative of behavioral health efforts in Oregon. I think it should be. I think you probably intended it to be described instead as representative of the behavioral health of Oregonians, not about the efforts. The efforts are being captured in the process measures. I think the global measures should be about the status of behavioral health of Oregonians.
Yeah, that's a good point, Bill. And we'll make some change ups to the slide to reflect that because really you're right. The measures that were selected for the as global measures do reflect on the status of behavioral health for Oregonians. So it's a really good point. Appreciate that.
Great, thanks. Second comment is it strikes me that today's presentation is about process, the process of identifying, selecting measures and then applying them in the CCO and incentive program and so on. I would hope looking forward that the board should be focused more on outcomes and the global measures so that we can see if we're making progress and if not, why not. So that's just maybe it's a comment to the whole board. Thanks.
Yeah. Well, I can let the board answer some of that part. But the other thing I wanted to mention that I neglected earlier when Kristen also asked her question was that some of the measures that we ended up selecting, particularly the global measures, relied on some federal data resources, which have since been deleted from some of the websites and or changed. And that is some of the pivot that we're having to make. So even when we do get to the point in time where we're publishing this information and can get to deeper discussions about the actual data and what it means for the system and what we can do to impact the measures, we may end up with some gaps or we'll have to note future gaps where certain things are being discontinued, where we're relying on some of the federal data efforts and might have to pivot to more internal state efforts that might not hit at that global holistic measure that we were aiming for, but might have to serve as proxies given where we might stand with the data that we have available to us. So yeah, we're kind of entering in on and I think that won't be just behavioral health that'll be impacted, particularly for a lot of these global measures. So different times that we're entering into.
Yeah, oh, okay. We very quickly, we have about 1 more minute left for this. So I'm going to turn it to Brenda.
Thank you. I just, again, appreciate the presentation and I want to offer a word of encouragement, John, to you, Maria and Ebony. This is hard work, and the notion about staying with it, even despite the complications of what you just described today, or getting weighed down by the sluggishness of process sometimes can be frustrating for you all, for communities, for the board, all of that. And yet my belief is that with the incremental progress that we make over time, and when we push toward and stay the course, we can actually make a big difference. So I appreciate the presentation and sort of the recognition that it is pretty heavy lifting. Maria, your comment earlier around sort of not going so fast at the speed of light that we lose community, really important reference point. And also this board holding the tension that we do want outcomes, and that's the offering that we, the board, can bring to you all, is to be that counterpoint to continue to draw improvement and to draw innovation in this space. So I want to thank you all for that. Thanks for the time, Kirsten.
Thank you.
Thank you. Thank you, Brenda. Thank you, Maria and John. Okay. Up next, we welcome back the Resilient and Talented Healthcare Provider Incentive Program to present its updated administrative cost budget. So just as a refresher, the Health Policy Board approved HCPIP's 2025 to 27 budget for program costs and only approved the administrative costs at the amount currently allowed in the 23-25 budget. So today the program team will present its updated budget for administrative costs, and we'll have time for questions and discussion before we're asked to vote on the approval of the updated budget. So Chris DeMars, Health Analytics Manager, and Melina Moran, OHPB Liaison to the Healthcare Workforce Committee, are going to kick things off for us. And Chris, begin when you're ready.
If you don't mind, Kristen, do you mind if I start?
Not at all.
Okay. So first, I appreciate the board's approval of the budget in our September meeting so that the incentives could continue without interruption. And as you mentioned, the board asked for more information on the cost regarding the administrative cost. And so the healthcare provider incentive program staff are here. Chris is here to present more information. Importantly, I want to acknowledge the timing of this approval request and the request for the administrative cost budget. It couldn't be worse with the cuts that Oregon is experiencing from the federal funding cuts, and we're asking, or the program is asking, for an increase in administrative costs. So I want to acknowledge that. But despite the unfortunate timing, I really believe these incentives are and associated administrative costs are crucial to Oregon's healthcare workforce, to the students, the healthcare professionals and practices who rely on these financial resources to address workforce shortages. It helps us provide culturally responsive care to our patients, and funding this program is a key part of a high-functioning program. So right now, I really believe that we must continue to invest in a culturally responsive healthcare workforce rather than backslide. And that includes approving these incentive program administrative costs so that the team has the support and staffing that it needs to support the recipients of these funds. So I've reviewed the slides and they have been sent out, and I believe you all have. I'm impressed with the quality of the work that the team has done and how seriously they've taken this exercise. And I will turn it over to Chris DeMars for her remarks. Thank you.
Hello, good morning. Thank you, Melina. Thank you, Health Policy Board members. I just want to make a few opening remarks before I turn it over to the program team. I want to let you know that we at OHA heard you at the September meeting. We are completely aligned with the importance of being efficient with the healthcare provider and center program administrative funds. We looked closely at the administrative budget, and as you'll hear today and see in the slides, we were able to identify a $150,000 reduction in administrative budget that would go directly into incentives. And I also want to point out that while it's not in the materials that you'll see today, that $150,000 reduction will be reflected in the next biennial budget as well. And I also want to just remind you all that what you'll be voting on today is a not to exceed amount. It's possible that not all funds spent today, that not all funds in the budget today would actually be spent. So thank you so much for your time and for your deep interest in this program. I'm now going to pass it on to Neela Gupta to take you through the slides with her team. Thank you.
Great. Thank you, Oregon Health Policy Board, for having us here today. As Chris mentioned, my name is Neelam Gupta. I'm the Director of the Clinical Supports Integration and Workforce Unit, and I'm joined by colleagues from the Healthcare Provider Incentive Program, I will turn it over to Alyssa and Jill to introduce themselves.
Yeah, hi everyone. I'm Alyssa Sloan. I use she, her pronouns, and I am the new Healthcare Provider Incentive and Project Coordinator with the Healthcare Provider Incentive Program. I just started under a little 2 months ago, so I'm still very new to the team and, still learning about all of the incentives that the state of Oregon offers to our workforce. But it's been a great learning opportunity so far, and I'm looking forward to working with you all.
And hi, everyone. I'm Jill Boyd. I use she, her pronouns, and I'm the lead healthcare provider incentives coordinator for the Healthcare Provider Incentive Program. And I have been with this program in the state of Oregon for almost 3 years. So happy to be back. Thanks again for having us today.
So this slide has an outline of the presentation we're going to walk you through today. We're going to start with just a recap of the September OHPB presentation and the purpose of today's presentation. We'll provide an introduction to the cost modeling exercise you asked us to undertake, and then we will review the data. And you also asked us to project administrative costs into future biennia, and we'll describe some of the challenges we experienced in doing that. We will take questions at the end of the presentation, but also we will stop at the end of each section in case you have questions. We want to make sure we get those addressed. And then lastly, we will present the administrative cost budget for the OHPB approval vote. Next slide, please. So as I know was mentioned, and to provide a little bit more context, this budget approval of the Healthcare Provider Incentives Program biennial budget was initially approved by the Healthcare Workforce Committee in August 2025. And as you heard already, OHPB approved the incentives budget line at the September meeting, as well as the administrative costs at the 2023-25 biennium level. And in addition, requested additional information on the administrative costs budget line. They are program costs, which we have defined as both indirect and direct program costs to administer these incentives. And slide 12, which Alyssa will be presenting, will have more information about this. You've asked us to provide cost modeling on how the increasing cost per recipient, and we've excluded one-time periodic costs and indirect program costs, such as legislatively required reports. And then secondly, what is a reasonable cost per recipient that could be used to serve as a baseline for understanding how administrative costs would change for future biennia? And so we're here today presenting the requested information and seeking your approval on the administrative cost budget. And I want to point out to you that in the September meeting, we requested $4.34 million in the administrative costs, or 14.3% of the overall budget. Next slide, please. This is a preview of the proposal we're going to be bringing back to you later on today for your approval. This is a detailed breakdown of, again, our estimated costs allocation cap. I just want to reiterate what was already said. This request is a cap, and any unexpended balance will be spent on incentive costs. And I know, again, as you've already heard, we have proposed a $150,000 minimum reduction in the administrative costs, which you'll see in the column, the revised proposal. It impacts our contracts and agreements. Those are variable costs. We have fixed costs, which we have less flexibility on adjusting. And more information will be provided about that later on as we go through the presentation. And so that amount has been reduced again by $150,000 to $4.19 million, or 13.8% of the overall budget for this biennium. Next slide, please. All right, now we're gonna, well, let me stop here and see, does anyone have any questions about what I just presented? Okay.
Not seeing any hands, Neelam. Thank you, though.
Great, thank you. So we'll keep moving and we'll start talking about the cost modeling introduction. Just wanted to provide you with some context on the program and the healthcare workforce landscape. The staff are a specialized, experienced team. As you saw in the response to the ORH, the Office of Rural Health contribution to this team has over 20 years of experience in delivering provider incentives, and these incentives are designed to recruit and retain the healthcare workforce that provides direct patient care to a significant proportion of Medicaid and Medicare patients. And since the COVID-19 pandemic, it's no secret to all of you, but there have been shifts in the healthcare labor market that have resulted in increasing workforce shortages, particularly in rural communities, as well as ongoing and worsening challenges related to workforce wellness, diversity, development, and retention. And as a result, I started at OHA about 5 years ago, and we've experienced incredibly increased interest in these incentives. And that interest has come from a wide range of partners, including healthcare professionals and practice sites, the Healthcare Workforce Committee, as well as other OHPB committees. Our team recently provided a presentation to the Medicaid Advisory Committee. Also, all of you have expressed interest as well as educational providers and legislators. And as a result, the program has grown and expanded since its formation through the legislation that enabled it, House Bill 3261. And more information will be in the next slide about that. Next slide, please. So this slide provides more information about the evolution of the Healthcare Provider Incentive Program since formation. We've seen a steady increase in the number of recipients across all incentive programs. You'll see that in some of the subsequent slides, as well as I wanted to highlight that we've seen especially sharp growth in applications and awards for two incentives, loan repayment and loan forgiveness. In response to feedback we received from a variety of different sources, some listening sessions we did with community partners. We listened to over 30 community partners. We also received feedback from the Oregon Health Policy Board and the Healthcare Workforce Committee, as well as healthcare professionals and practices. We broadened our incentive offerings to include new disciplines and additional types of incentives since the Healthcare Provider Incentive Program was formed. We also provided subject matter expertise to the Behavioral Health Workforce Incentives Team that was established through House Bill 2949 in 2021 to distribute funding. And we also received an additional $6 million to our budget in the 2023 session. And all this increased investment was through legislative action. We also experienced a multi-year effort in implementing race, ethnicity, language, and disability data collection, REAL-D data. We consulted with OHA experts to help them understand the unique nature of these workforce incentives, and worked with them to design tailored tools and processes and support contractors in integrating this data into their efforts. And then, all of this led to growth in our staffing to meet these increased programmatic demands. We received additional legislatively allocated staff, and we also increased our external support as well. Next slide, please. And I will turn it over to Alyssa.
Thank you, Neelam. Before we dive into the cost modeling analysis, we did want to illustrate how the healthcare provider incentive programs have grown over the years. So in this table, you can see the number of incentive recipients for each program in the 21-23 and 23-25 biennia, as well as the estimated number of recipients for the upcoming biennium. There are a few key takeaways we want to draw your attention to. The first is that recipient growth has varied among incentives that have existed prior to the 23-25 biennium. So you can see that PCLF recipients are expected to increase substantially in the next biennium, with an expected 136% increase from the 21-23 biennium. On the other hand, you can also see that rural medical malpractice insurance subsidy recipients are expected to decrease. And we'll talk a little bit about why we think that is in a moment. The second key takeaway is that the new incentives, which include the career pathways and retention scholarship programs, are largely responsible for the increase in healthcare provider incentive program recipient growth overall. These programs are expected to serve over 2,500 students and providers between the 23-25 and 25-27 biennia. And we will talk more about the approach we took to cost modeling in a moment, but we did want to note while we are here that we included the Scholars for a Healthy Oregon Initiative, or SHOE, in the table here for your reference, but we did not include this incentive in our cost modeling because it is supported by pass-through funding. So for those of you who are not familiar, OHA is required under separate statute to pass through a biennial legislative allocation of $5 million to OHSU to administer SHOE and provide annual reports to the Healthcare Provider Incentive Program. Next slide, please. Here you can see the estimated % increase in recipients per program in the upcoming biennium compared to the 21-23 biennium. I do want to call your attention to the bar farthest to the right. That represents the % increase in recipients for all incentive programs overall. So over 3 biennia, the estimated number of recipients are expected to increase by 169%, which reflects significant program expansion. And we did want to note that the expected decrease in rural medical malpractice insurance subsidy recipients is attributed to the 7-year participation cap and the growing number of providers receiving malpractice insurance through other group coverage arrangements. But again, overall, we are expecting a 169% growth in incentive recipients overall. Next slide. We also wanted to highlight the growth we have seen in the demand for some of these programs, which are exemplified by the increase in applicants for the loan repayment and PCLF programs. We estimate that the number of loan repayment applicants will increase by 100% from the 21-23 biennium, and that the number of PCLF applicants will increase by 79%. Next slide. So we wanted to share all of that as context for the cost modeling analysis that we conducted at the board's request. Are there any questions for us before we dive into the cost modeling data? Okay, not seeing any, we can move on. So as requested, we developed a metric to better understand the cost per healthcare provider incentive awardee or recipient over time. At a high level, we calculated this metric by taking the allocated budget for direct program costs divided by the number of awardees. Direct program costs include things like staff time dedicated to the administration and implementation of incentives, incentive-related travel, office supplies, and software licenses. But Jill will provide more details into what goes into those program costs later on in this presentation. We do acknowledge that administrative costs include both indirect and direct program costs, but we are not including indirect program costs in our calculations because they are not directly related to the implementation of incentives. Indirect costs include things like staff time dedicated to special initiatives, legislative mandates, or other strategic or high-level operational functions. And again, Jill will provide a little bit more detail on what those indirect costs entail on the next slide. We do want to share that to calculate this metric, we did have to estimate the number of awardees we think we will receive in the next biennium, and that those estimates are based on historical trends. And of course, we do want to say that this cost modeling metric is one way to measure efficiency, but it does not measure the effectiveness of incentives or staff impact on outcomes. So that is just something to keep in mind as we move through the rest of this presentation. And with that, I will pass it over to Jill.
Thanks, Alyssa. As Alyssa mentioned, I just wanted to kind of do a brief highlight of some of the indirect costs that are not included in the cost modeling analysis. Aside from the additional administrative costs such as travel, everything that kind of keeps our jobs running from a remote perspective, equipment and other cell phones and license agreements. We also had some additional indirect costs that I wanted to call out, such as developing the healthcare incentives evaluation report, which you just all reviewed. Feels like a long time ago, but it was just this summer that you reviewed the 23-25 legislatively mandated evaluation report, which we compiled with our program staff, as well as supporting and providing data and other support needs for the needs assessment report, which is also legislatively mandated every 2 years as well. We also had significant time during long session. We don't spend quite as much time during short session, but any type of legislative requests that come out during legislative session or prior to, we wanted to highlight that because that is a significant portion of our time because workforce bills seem to be very, very critical at this point in our work that we do. And then finally, in addition to all this other stuff, revising our administrative rules, which was specifically highlighted in the 23-25 biennium and are continuing on through the 25-27 biennium. We are required as part of revisions of any administrative rules to partner with the Department of Justice, which requires some additional costs to support any type of rule revision review, as well as staff time to do that. So there was significant amount of staff time, and if anybody's participating in our Rules Advisory Committee or is looking for more information about that, we have our first Rules Advisory Committee meeting on Friday, and you'll be able to see the extensive revisions that we're undertaking during this biennium. Next slide, please. But this is what we really want to be able to highlight for you all. So while we talked a little bit about the indirect program costs, this is the cost modeling analysis for the direct program costs per awardee. So we wanted to make sure we included some comparison information from the 21-23 biennium, 23-25 biennium, and then our projections for the 25-27 biennium as well. So you'll see that the aggregated data on this slide indicates that the overall direct program cost per awardee, which we're estimating is about $1,500 for the 25-27 biennium for all of the programs combined. And this does exclude SHOE, as Alyssa mentioned back a few slides, I think slide 9 above, that excludes SHOE since that's a pass-through fund, that we have seen a decrease since the 21-23 biennium. You will see a slight increase in the projections, and that's, due to some of the non-negotiated cost of living and union negotiated rates. And so those are also estimates and projections, and they don't actually represent the final amount that we will be able to show at the end of the 25-27 biennium. We'll be able to see actual costs as we do projections for the 27-29 biennium. We did have some issues with providing a cost per recipient calculation for each incentive. That was going to require some retroactive estimation of staff FTE, and at this point in time, it just was not possible to be able to capture that information. Next slide, please. I know this is quite a busy slide, so I'm not going to spend a ton of time on this, but because I wanted to highlight this work in story form for you in the next slide. But I just did want to highlight, and you guys can review this on your own as well, some of the work that we actually do by incentive. So this is kind of a breakdown of every single thing that we do within the 7 incentives for each. Each incentive has some of its own unique staff roles. Some of them are very similar, but they all require an extensive amount of work that's done, not just for applicants that we do for loan repayment and loan forgiveness, but also for the awardees that we do for all the other 5 programs. These are including outreach and marketing, monitoring and conducting the application systems, reviewing loan eligibility assessments, both for loan repayment and for any other, just for loan repayment. Any sort of database management, tracking service commitments, which for some of our programs can be a substantial period of time, up to 9, possibly even 10 years, managing life changes such as site transfers, processing invoices. If people go on paternal leave or have some sort of military leave or extended service, or extended illness, then they also could have a temporary service suspension, and we will need to create additional amendments and paperwork around that so we can track their time. Same thing for primary care loan forgiveness, a lot of work with students as they're going through their educational system or educational process upon graduation, and then all the site visit requirements for that. For the rural medical practitioner insurance subsidy, doing a lot of rate setting review requirements, working with insurance carriers, making sure we're able to track eligibility, process invoices, make sure everybody's eligible, including practice sites, and then manage site transfers and any other technical assistance. We do include SHOE because there's a little bit of work that is involved with SHOE that includes, monitoring and managing their contract agreement. So we don't just hand over $5 million every biennium. We do have some contractual obligations between OHSU and OHA. We also process their invoices. We are working on some RealD data collection processes, tracking their deliverables, and then also providing technical assistance. And then, of course, for our scholarships, career pathways and retention, we do all the grant solicitations, we draft the grants, we review and award the grants, we conduct all the invoice processing, complete all the contract amendments, monitor compliance, data collection, RealD data collection, track service commitment if it's applicable, and then provide technical assistance to grantees as needed, which for these incentives can be a little bit more than some of the other more well-established processes that we have. Next slide, please. So here's a few stories that I wanted to share just to kind of show you on an individual basis what we're kind of looking at in terms of the work that we do here at the Healthcare Provider Incentive Program. So for loan repayment, we had a provider who we still currently have with us, has had multiple children and has had a major life change. And since with that life change, they needed to shift their status several times and require extensive staff support. So over the course of 6 years, mind you, this is a 3-year loan repayment service obligation. They've had to have 7 amendments to the loan agreement, 4 temporary service suspension approvals, 2 site transfers, and a change in service commitment from full-time to part-time, given the provider's extenuating life circumstances. When you have 4 children and you want to take paternal leave, every single one of those requires a temporary service suspension, which also requires an amendment, which also requires suspending any invoice payments, and then making sure that they are, we're communicating with that provider to make sure that once their parental leave is over, that they're returning back to the same place. And this person, because of their extenuating circumstances, ended up moving and needing to change sites multiple times. So this is just one person, right? Out of the over 200 individuals that we're currently serving. So for primary care loan forgiveness, we had a recipient that received a naturopathic residency, which is somewhat unusual, I think, is what we've been told. And that was for 2 years out of state. So once they graduated, they haven't even begun their service commitment. So we really needed to make sure that we could work to connect with them and monitor the recipient post-graduation for the time that they're doing their residency. And then once they complete their residency, make sure that we can come back and track their service commitment, because they're still obligated to complete their service commitment. So what was a 1-year possibly award for primary care loan forgiveness turned into a 4 to 5 year service commitment tacked on to a 2-year residency program. We also have to confirm that when they do come back, that they employ at a qualified practice site. We have wonderful Oregon Office of Rural Health staff that helps with site placement using 3RNet. And then we also provide technical assistance as needed because these students are, there's a lot of life changes that can also happen between graduation and residency before they even begin their service commitment. So that's just one other example. For the rural medical practitioners insurance subsidy, even if just a recipient decides to switch insurance carriers, which does happen, we do have to confirm the eligibility of the insurance carriers. All insurance carriers that are approved for this program must have a certificate of authority on file with the Oregon Department of Consumer and Business Services, or DCBS. We have to renew their provider application for eligibility to determine that they are both at a qualified practice site, as well as they continue to be an eligible provider within the program. And then making sure that they have the correct percentage subsidy coverage with the new carrier, and then ensure that the coverage is monitored yearly. For our healthcare workforce scholarship recipients, we're estimated about 2,500 of those. This is just one example of a recipient that's received a full scholarship for a physician associate education program. So not only do we need to collect a letter of service commitment while they're in school so that we can kind of track them and monitor them over time, and they agree to practicing at a qualified practice site upon program completion. We also assist with site placement. We have to collect site applications for their eligible practice sites. And this is all happening, once they begin graduation from the program. So this could be multiple years in the making as well. And then monitoring the fulfillment of the service commitment upon program completion. So we're looking at, if a 2-year PA scholarship is awarded, we're looking at 2 additional years of service commitment, which we have to monitor on a yearly basis. We also collect RealD data for all of our awardees, and then be able to provide any sort of technical assistance as needed, especially for students who, again, a lot of these students are looking to an abundance of potential life changes, and we want to make sure that we're supportive of this process. I'm not going to go over these, but we also have some recipient testimonials. We really wanted to tug at your heartstrings today, and just kind of share with you some of the impact that we're seeing with these recipients and the work that we do. It is life-changing for a lot of people. We hear about this all the time, and we just wanted to share a little bit of that work with you. Next slide, please. Okay, and with that, I'm going to pass it back over to Neelam to wrap us up. Thank you.
Yeah, thank you, Jill. I just wanted to pause and see if anyone had any questions about the information we just presented.
I have one question. Thinking about, Jill, I'm hearing you say, which was not a surprise when you said it actually, because in your description of the programs, like some applicants, it's 9 to 10 years actually of staff engagement. And so when we think about the graph, about the kind of per awardee in each biennium cost, like that is a graph of the new awardees in that biennium. But if we're thinking about the total applicant work, am I correct in thinking there's a cumulative, because that the applicants awarded in that first biennium are still requiring staff touch points and efforts into later bienniums, even though they weren't awarded them?
Yeah, so we're looking at, when we did the direct program costs modeling analysis, we only looked at awardees. So we did not, so those are kind of, because not every incentive has an applicant process, right? So we wanted to look at that. So that doesn't include, the multitude of applications that are being reviewed as well. Those are just the work that we commit to the awardees. And I'm leaning towards Alyssa because I think we did change this a little bit over time, but I believe we did include in that analysis that is presented in slide 14, I believe we did include not just new awardees, but we tried to gauge on a 3-year commitment, which is standard for loan repayment, and it's 1 to 2 years for PCLF. So we didn't include that, but we did calculate the cost per awardee, that it does include new awardees as well as current. Yes, current. So that's spread over the 3-year time. Yeah. Thank you for that.
Thank you.
Comment. Yeah.
And if I could just add on, I think to Jill's point, that's the average amount, but in recent years we have seen, for life reasons, more an extension of that time.
Yeah, this is estimating everything's going well, that we don't have every recipient as our loan repayment example that's having multitude of life changes that we want to be able to continue to support. So, yeah.
Thank you.
I'm just going to give it another 5 seconds to see if anyone else has questions. Okay, all right. So I'm going to then present on the challenges we experienced in projecting administrative costs into future biennia, because that was also part of the information that OHPB had requested in the September meeting. Next slide, please. So, again, I would like to kind of frame this as fixed costs, the costs that we don't have control over, and then variable costs, the costs that we do have control over. Costs beyond OHA's control limit the ability to develop a cost rubric, I think was the way it was termed, with certainty. As a public agency, OHA receives a biennial budget allocation from the legislature, and that makes future funding levels difficult to predict. I think particularly at this time with some of the context that was provided in the introductory remarks. And then, some costs are fixed, such as, and have increased, such as union negotiated salary increases, cost of living adjustments, and shared services. And those have also varied significantly across past biennia. So that also makes it difficult to predict into future biennia. And then many administrative cost line items are mandated by legislation and cannot be removed. And so, our fixed costs include our staffing and the legislatively mandated reports. And the only potentially adjustable costs are those variable costs, which are related to our contractors. Next slide, please. I'm going to keep going unless anyone has any questions, because we've been taking questions throughout the presentation, and provide the budget that we're going to be voting on. So this is, again, you've seen the slide at the beginning, and this is just to reiterate the detailed breakdown of the 4.19 million proposed administrative costs. Again, this request is a cap, and any unexpended balance will be spent on incentive costs. And OHA has proposed a minimum $150,000 reduction in those variable costs in the contracts and agreements. And that reduces the administrative costs amount to 4.19 million, and the percentage of overall costs to 13.8%. That reduction will be reinvested in incentives. I'll just stop here and see, does anyone have any questions about that?
Looking for hands. If I'm missing any, let me know. And Neelam, correct me if I'm wrong, but some of the expenses that are in that contracts and agreements line now, because we want to do things like this provider incentive evaluation design, some of those expenses are one-time investments.
Yes. We we have two legislatively mandated reports that are required every biennium. We have contracted out the past two reports for the healthcare workforce needs assessment, and we've conducted the provider incentives evaluation within our team. And we heard from OHPB when we went for the approval that there was a desire to do a more robust evaluation. And so what we proposed is what could be a one-time cost to work with a contractor to help us design the evaluation so we could truly understand the effectiveness of these incentives and where we should be investing more in and where we should adjust.
Appreciate that. Tony, go ahead.
Well, thank you all in doing this investigation and look. And, to that point, Neelam, really appreciate that evaluation and that process to kind of learn a lot of the programs in front of say are really tremendous. I'll just add on to that list of how great these programs are. I would not be practicing in Oregon if we're not, I'm no longer part of any of these programs. This is many years back. But it does support our workforce because it is such an upfront investment to get into a number of these healthcare fields. And so I think we see that the challenges that we're faced with the scarcity of our nursing colleagues, our primary care colleagues, our behavioral health, we need investments in these. And I am really excited about this in front of us. I guess just one of the things is looking at, continue to be an evaluation. And so it sounds like that evaluation and we'll look at, how the efficiency is ongoing with these programs. So we want to continue to learn how we can make them most effective and meet the individuals that are most impacted in their ability to get into the workforce. So it sounds like that is part of this bucket that we'll see that in the upcoming 2 years will be the next report. Is that correct?
Yes.
Great.
Yeah, these reports, as Jill mentioned, the evaluation was approved this past summer. The needs assessment was due to the legislature by February 1st. So that was approved by OHPB in January. And we will be going, these next set of reports will be presented to OHPB in January of 2027 for approval.
Thank you. Bill, go ahead.
Neelam, I want to thank you and Jill and one other person, I'm sorry, who was part of this presentation, and also Chris for your leadership on this. I know this was probably not a fun task, but I appreciate the analysis that you all have gone through, and most important, appreciate your proposal to reduce the administrative costs, not just to reduce administrative costs, but to redirect those funds toward these very, very important programs. So thank you for your efforts, and I think this is a good proposal moving forward. It gets the money, I think, more directed to these important incentive programs to address our severe workforce crisis.
Thank you. Thank you for that. And I just want to especially thank Jill and Alyssa, who work on the administration of these incentives every day with our colleagues from Office of Rural Health.
Wonderful. Melina, go ahead.
Yeah, thanks. I just want to echo just both Tony and Bill, and first thank the team. I think taking the time and doing this deep dive is just really shows where the funds are going, and just really provides the board with more important information. And I just really appreciate the work and just I want to say thank you. And then again, just the importance of this program. Yeah, I just want to say thank you. And I don't know if I can make a motion if I'm not voting. Am I allowed to?
Sure, help us out. Bill, you know the answer?
I'll save you, Melina. I'll make a motion to the board to approve the revised proposal for the administrative costs as put forward in this slide.
This is Peter. I'll second.
Oh, Peter got it.
Okay, so I'm hearing a motion by Bill to approve this revised budget and a second by Peter. Terry, do you want to take us through roll call, please?
Sure, I'm happy to do that. And I'll just remind everyone, we have 3 members that will abstain from today's vote. That's Dr. Hemmings, Brenda Johnson, and Melina Moran, so I will not call their names. First, Peter Starkey.
Yes.
Hayden Rickley.
Approve.
Bill Kramer.
Yes.
Kirsten Isaacson.
Yes.
Tony German.
Approve.
Great. So of the 5 members who are eligible to vote, all 5 said yes, and that is enough for quorum, so the budget is approved.
Excellent. I want to thank the healthcare provider incentive team for being so responsive to the Oregon Health Policy Board. I think today's meeting and answering all our questions in the last month is not the only example of that. Like, I think about how we've talked about pathways and going into different career fields. That has come true. I feel really like you really heard the board when we've asked about, like, hey, let's have a real report that like really delves into like not just what happened, but like what is the most efficient investment Oregon can make to really meet our healthcare workforce needs, delivering care to people like where they need it in different geographies and in specific communities. And I feel anyway, and then today with taking a second look at that budget, establishing it as a cap, I just want to acknowledge the hard work of this team and the exceptional responsiveness and their dedication to the work and to the state of Oregon. So thank you. And thank you for doing it in a transparent, public way. That's also added stress. And with that, it is time for a break, which we have all earned. So it is 10:10. We will take a 15-minute break and return in 15 minutes for public comment. Yeah. Thank you, everyone. Oregon Health Policy Board and we are going to move to public comment next. The Oregon Health Policy Board welcomes and deeply appreciates public testimony. It's actually one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with careful attention, respect, and honor that you deserve. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual. It's not a representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share, and in the event that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. And to help keep us on time, we'll have a 2-minute timer for each commenter. We kindly ask that commenters conclude their presentation when the timer is complete. And please know that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine appropriate next steps. And so with that, first up is Dan Cushing.
Thanks, Kirsten.
Dan,
Hi, everyone.
begin when you're ready.
Hi, thanks. My name is Dan Cushing. I'm the Government Affairs Director for Yamhill Community Care. I'm here today to speak about an important issue, which is the prioritized list. The prioritized list is critical for the benefit design of the Oregon Health Plan and ensuring access and sustainability of the plan. So for a little context, about 1.5 years ago, Oregon Health Authority announced that it would eliminate the list, which surprised a lot of people because when the waiver was approved in 2022, the state officials at that time promised the list would just simply move from our waiver into our Medicaid state plan through a state plan amendment, or SPA. So Oregon is the only state that, as far as I know, with this kind of transparent evidence-based process to determine what the covered benefits will be for Oregon Health Plan. And the list has enabled Oregon Health Plan to cover more than 1 million people while adding key optional benefits like adult dental, vision, and podiatry. I believe, and many people agree, that the waiver doesn't require us to eliminate the list. It just says Oregon has to transition authority to align with state plan rules. Yet Oregon Health Authority is proposing a vague 3-layered bureaucracy. These 3 layers are medical necessity, mandatory versus optional, and in or out of package. My fear is that for patients, it's going to be really unclear who makes those decisions. And as a state policy issue, how evidence is going to be weighed versus the lobbying influence of big pharma. The danger is twofold. Benefits could either vary wildly by region, or the benefits and the cost could balloon out of control as many things will be deemed medically necessary. Now, in the limited time I have left, I just want to speak to, I know that people are saying that this has to be done according to the waiver, but I think we could get a lot more imaginative by enshrining in Oregon statute that we have to allow patients to get covered services that are below the line if they have individual medical necessity through medical review. Thank you for your time.
Thank you. Next, we'll turn to Josh Palick.
Hi, can you guys hear me? Okay.
We can.
Thank you. So my name is Josh Bellick. I'm the Vice President of Health Policy for All Care Health. We're a coordinated care organization out of Southern Oregon. And wanted to build on some of Dan's comments around the prioritized list. So I think what's very important here is to remember that currently there are no administrative denials for basically covered services. Every denial of physician is physician reviewed and can go to an outside specialist for future review. And then if that still doesn't meet the requirements or the needs of the member, there's an administrative law judge process that can overrule that as well. It's a transparent and accountable process. And the reason I'm spending some time here is this process is actually the way that we can move the prioritized list from the waiver to the state plan amendment to the SPA. By codifying that inside of statute, you would then be, inside of the SPA, we then would be in alignment with the state statute, which says Oregon shall use the prioritized list, and then we don't actually even have to change state law. Everything's kind of locked in. Unfortunately, what is getting proposed by the state right now is that we would end up moving forward with a medical necessity rule standard. And the medical necessity standard that Oregon has in statute is incredibly wide open in comparison to many other states. Basically, it allows for everything up to the potential of mobility, which means that any creative doctor, any creative advocate out there can find ways to be able to get things that maybe aren't the most evidence-based to get covered. And there is no proposal to remove that wide open medical necessity standard out of the state. So we haven't even talked about drugs. We haven't even talked about increasing costs. And frankly, I think some of the underestimated things that are there. I think this is something that the agency really should, the Oregon Health Policy Board should be getting very involved in and really asking some great questions. I apologize for running over. Thank you.
Okay. Thank you. Next up, Ann Casper. And followed by Ann, we'll go to Jason Bowman and then Samantha Shepard. Ann, are you with us? All right, then we're going to proceed to Jason. I'll check back in with Ann later. Jason Bowman? Okay, Samantha Shepard?
Hello, thank you. Good morning. I'm Samantha Shepard, Executive Director of CCO Oregon, and I'm here today on behalf of a coalition of provider organizations and CCOs. We've also submitted a written comment that is available online for you. We want to call your attention to a comment that we offered last month in the Metrics and Scoring Committee that raised concerns about the proposed reduction of quality improvement or QIP funding in 2025 and 2026. The Quality Incentive Program is a cornerstone of Oregon's coordinated care model and one of the state's most effective tools for improving health outcomes, reducing disparities, and rewarding high-quality care. Providers and CCOs take these measures seriously and work hard to achieve them, and it's not easy. For 2025, the proposed rollback would result in providers not being compensated for services that are already delivered. Moving forward, if QIP funds are reduced or eliminated, providers will be forced to scale back or discontinue the very programs that improve care coordination, preventative health, and chronic disease management for Oregonians. Further, we are concerned that the 2026 CCO contract includes no protections for the remaining QIP dollars, meaning ongoing budget pressures could further reduce the program. Reducing the QIP undermines the very goals Oregon has pursued for over a decade: better health, better care, and lower costs. At a time when workforce recruitment and retention challenges, cost inflation, and the potential impacts of HR 1 threaten access to care, eliminating quality-based incentives would only make matters worse. To the Metrics and Scoring Committee, we requested that if the QIP funding is not restored, that the committee reduce the number of metrics and expectations of the program. Our request to you, the Oregon Health Policy Board, is to hold time on your December agenda for system partners to discuss the Quality Improvement Program with you. We would like to organize a panel of speakers and have 20 or 30 minutes for discussion. Now more than ever, Oregon must protect QIP funding to sustain progress and ensure equitable, high-quality care for all Oregonians. Thank you for your consideration.
Kirsten, I think you're muted, or maybe you're trying to come off mute.
Thank you for flagging that. Talking to myself. Thank you, Samantha, for joining us. And I was checking to see if Ann Casper or Jason Bowman had logged on and would like to share their thoughts. And unless we hear from them, and I think last we checked, we weren't seeing them as on the Zoom, then we will officially close public comment. But appreciate everyone who spoke today. And I know that we have an additional multiple written comments that we shall review. Okay. With that, Claire is with us. Thank you, Claire, for being ready to roll a little early. Claire Pierce-Robel, Director of OHA's Health Policy and Analytics Division, joins us today to provide agency updates and to engage in conversation with members about the connections and potential collaborations between OHA and the board. Claire, thank you for being here, and begin when you're ready.
Thanks so much. Happy to be with you all this morning on this what's shaping up to be a lovely fall day. As Kirsten noted, a few things that I wanted to touch on from the Oregon Health Authority today include, I think, what we've been asked to provide each month to the board, which is an update on our response to federal government changes. I'll also speak to the shutdown in particular. Also asked to speak to any changes to coverage or access based on those changes. And then I'll just close by giving a quick update on the state of the OHA budget and activities that we're going through to be responsive to the most recent economic forecasts. So first, as I've shared and our Director Hathi has shared in this forum before, we have a team that's been and a structure that's been set up between OHA and the ODHS to specifically respond to and implement HR 1. And more broadly speaking, we have a structure in place to be able to respond to federal policy changes out of the director's office. That's the Federal Response Planning Team, which coordinates the work across our agency and, again, in partnership with ODHS. And so that continues to be where I would point you to for any updates on that website, the OHA Federal Response Planning Team website. And that will be the latest when it comes to any information that we have to share specific to, again, I think the most pressing questions around access and coverage. A few things new this month that we are continuing to watch. That includes the impacts to OHA programs from the federal government shutdown. I'm going to give an update on at least one of the multi-state litigations that we are participating in, or the Attorney General's office is participating in, and then changes around, or rather clarifications around Healthier Oregon and OHP coverage and eligibility. So in terms of the shutdown, as you're all aware, and frankly, what's been, interesting to watch, that in the past month, since the federal government shut down on October 1st, I think the awareness of what the term enhanced premium tax credits mean has taken on kind of a new life, as that's a cornerstone of the conversations around the negotiation to reopen the government. Obviously, something that we are watching very closely. Our open enrollment has kicked off, and so those premiums that I've discussed before that are expected to increase for Oregonians, the 80% of the 140,000 folks that do get coverage through the Oregon health insurance marketplace, are starting to see what the impact of that will be. So we're obviously monitoring those discussions and what will ultimately be congressional action or not around that extension. At this time, Oregon health plan members are not affected by the shutdown. OHP services continue as normal. There are no immediate changes to coverage or provider access expected in the near term. And on the other side of OHA, with our public health division, the USDA has provided additional funding to Oregon's special supplemental nutrition program for women, infant, and children, the WIC program, which enables WIC to continue into November. So at this time, we're not aware of other OHA program impacts in November, but again, we're monitoring closely and remain focused on providing that continuity, care, and access. So again, I'll reiterate any federal changes. We're using that website to share resources and update our partners and the public on the shutdown, and encourage folks to check that out for the latest information. And then when it comes to PRORA, the mumbliest acronym of them all, the Personal Responsibility and Work Opportunity Reconciliation Act. Just to quickly provide the update on that multi-state litigation that I mentioned. So in August, the Oregon DOJ joined 20 other states in suing the federal government over the new rules. Those rules would have imposed new immigration related restrictions on a variety of public benefits, including OHA's Title X family planning program and our mental health programs. And on September 10th, a U.S. district judge issued a preliminary injunction. So what that means is that it prevents the changes from taking effect, and that preliminary injunction is still in place today. So that is the latest on PRORA. Then when it comes to other OHP impacts, as this board knows very well, 1.4 million people in Oregon rely on OHP for health coverage. And as I mentioned, to respond to the changes required by HR 1 across eligibility, across new work requirements, across the just dramatic changes to the financing system when it comes to provider taxes and state-directed payments. We have set up work streams to plan and implement to those federal requirements. And specifically, I would say we are very hard at work preparing the multiple different IT system changes that it will take to meet the federal requirements on the short deadlines that we have in front of us. So we are planning on that front while again remaining focused on keeping the people of Oregon at the center of our decision making, and keeping the goal of keeping people covered front and center while we work to comply with the federal mandates. I would say that we want to be clear that as a result of HR 1, there will be more frequent eligibility checks and a new work requirement for everyone that's enrolled in, or for some people that are enrolled in Medicaid rather. But it's really important to know that the thing right now to know is that OHP members do not need to take any additional action. Those policies are not yet in place. There are no actions needed around work requirements or federal changes at this time. Those requirements take effect in January 1st of 2027 for work requirements. They'll be applicable to OHP members at ages 19 to 64 without children or with children over the age of 13. And the eligibility redeterminations will also go into effect in 2027, but later in 2027, once the waiver expires, our continuous eligibility waiver expires. So we will be communicating more about these new requirements. It's really going to be an all hands on deck effort to make sure we are communicating out through every channel and looking to community partners to get that message out as well. But I think the thing we want to make sure is getting that the message that is getting out today is that no changes have gone into effect, and OHP members and those who are eligible should continue to access the program as it currently stands. And then finally, on the coverage updates, just a quick note on Healthier Oregon program, which I know members of the board have also asked that we make sure that we are providing updates again, whether we have updates or not, because sometimes I think that silence can be taken as a message, and we want to be super clear at this point that no changes have been proposed to the Healthier Oregon program. So we are proud to continue providing coverage, and the Healthier Oregon program serves over 100,000 children and adults in Oregon, including those who have refugee status, lawful permanent residents, people enrolled in DACA, individuals with student or work visas, and other adults that would otherwise be eligible for Medicaid except for their immigration status. So we are estimating that enrollment will increase, especially as other changes go into effect from HR 1. But the program has been fully funded through this biennium at the projected case levels that I mentioned. And so again, no changes are proposed. And we know that Oregon thrives when our communities are healthy. That includes our immigrant communities, and by prioritizing that health coverage for all, we know that means that all communities, economies, and people in the state can earn a living to support their family and their local community and make Oregon a better place for everyone. So that is updates on Healthier Oregon. And then finally, as I mentioned, just a quick note around our budget. So again, the state revenue forecast that came out after the legislative session closed really gave us a difficult starting place for this biennium. And there is a need for us to look across the board statewide at opportunities to reduce our costs to meet that budget hole and to balance the budget. So we at OHA are participating in a statewide budget planning exercise that was requested by the Legislative Fiscal Office as part of the state's ongoing efforts to prepare for the 2026 legislative session. So along with all executive branch agencies, OHA was asked to assemble a potential budget reduction list to help the legislature and the governor's office understand what the potential impacts are of budget decisions and to prepare for a range of fiscal scenarios. So a few things to emphasize. One, this represents different options, not decisions. There was no explicit directive to implement any budget reductions, and it's been really our goal within OHA from the leadership, and this is consistent with direction from the governor's office to make sure we're approaching this with equity, stability, and mindful stewardship as the core of our focus. So the next steps in this effort will be to present this information to the Joint Ways and Means Committee during November legislative days. And those materials will be posted publicly ahead of that presentation. We are, and I keep really close to heart that budget discussions can raise concerns, especially for our employees. And we are committed to keeping employees and partners informed as we move through this process. And again, keep our focus on the communities most impacted by any potential changes to be responsive to the fiscal situation that we're in. So I really encourage partners to watch the legislative hearings in November for more information, much more information, and we'll continue to engage openly with partners and the board, legislators as those discussions progress. So with that, I will turn it back to the chair.
Thank you, Claire. Any questions from board members or comments? Brenda, go ahead.
Thank you so much, Claire. I really appreciate the update today, including what you've done around the Healthier Oregon program. I think it's really wise to continue to keep the board and the public informed in the way that you are. So thank you very much for that. I wonder if you could share some more information about the Rural Health Transformation grant application. I think it's due tomorrow. If you could just take a moment to suggest if we're on track, anything early news you want to share with the group, that would be helpful. Thanks.
Sure, happy to. So as Brenda noted, the Rural Health Transformation Program Cooperative Procurement Grant is due tomorrow, November 5th. We were in the process of submitting our application, and I anticipate we'll press the final send button, submit button by the end of the day today. So not taking any chances with the federal shutdown and any systems issues. So we are, and we will also release and post on our website the full project narrative for the application and accompanying information, more plain language information. I think any of you that have worked on federal grant applications before know that that's really a technical document. It's intended to meet the scoring criteria and the specific rubrics and statutory requirements that are included in the notice of funding opportunity. It's not necessarily easy to read. So we will make sure to do our best to continue to communicate in a way that's clear and for an Oregon audience. Briefly speaking, and we've shared this in our public forums that we hosted last month, as well as in the materials that we released and the survey that we conducted to help us to refine the initiative areas. There are 5 initiatives included in our application that we are requesting funding for. The first is healthy communities and prevention. Again, kind of centering around ensuring that we have solid access points to primary care, that we're focused on chronic disease prevention, recognizing the disproportionate burden in rural communities and other challenges related to providing whole person care and with primary care as the foundation of that. As well as behavioral health. We are also looking at workforce retention as a second initiative and recruitment. So what can we do to make sure that clinicians are training, practicing, and living in rural communities through a number of different either incentive programs or bolstering training programs or pipeline programs, grow your own workforce programs that we're thinking as early as high school and as late as residency and everywhere in between on that continuum. We are also looking at investing and proposing to invest in advancing technology and data systems. So again, recognizing that there are efficiencies to be gained, especially when it comes to the purchase and implementation of new technologies. And there's also efficiencies to be gained, for instance, through an access to be improved through the use of telehealth and other systems, including telemonitoring, teletraining, and how do we make sure that we're building the infrastructure to make sure those access points are available in rural communities in Oregon. And then that gets to the last state-led initiative, which is regional collaboration and sustainability. So we are looking to encourage regions to really come together to better, first of all, define what can be better resourced in new creative ways, whether that's clinically integrated networks or, for instance, joint purchasing on some of those technology projects that I mentioned, and what are other things that, again, the state can be doing to facilitate that. Our intent is to both support in kind of phase 1 of our project, those planning conversations, and then in phase 2 to really incentivize those collaboratives to come together and request funding for additional projects, but really trying to build in sustainability from the front by having those foundations in place first, and then encouraging, again, joint investments and projects and implementation to happen directly in those communities and driven by those communities. And then the final initiative will be if we're awarded, I always have to say that, and there's no wood in my office, but I'll knock on it. There's a tribal initiative which represents a set aside consistent with Governor Kotek's commitment and consistent with our commitment to respect tribal sovereignty and self-governance. And so that set aside will be directed by the tribes in line with the requirements of the Notice of Funding Award, but again, respecting their sovereignty to do so. So the timeline, just to wrap up quickly, we submit today or tomorrow, and we will then be waiting for CMS to essentially grade our application. We are expecting there to be a merit review panel that's taking a look, and then later in December, we would likely be entering into budget negotiations, depending on where things stand. CMS is required under statute to respond and make awards by December 31st of this year. So, they gave us a 6-week deadline for the application. They have themselves an 8-week deadline to let us know. And then awards would be starting sometime after that. So our expectation is that we would put out more detail on the requests for proposals and what will be funded, again, in those phases 1 and 2, but primarily focused on phase 1 in the first year to get those dollars out the door as quickly as possible, because we will only have a 9-month budget period in that first year. So timeliness is going to be our focus. So maybe more than you wanted, Brenda, but there you go.
It's just perfect. Thanks, Claire. Thanks so much.
Any other questions from board members? Connie, go ahead.
Claire, thanks for being here. Man, what a list of things to go through. And I'm just amazed how you are all dialed in on every aspect of that, and gives me confidence in just, what OHA is doing and in good hands and leading our stewardship in the times we find ourselves. I had a question back to OHP and regard to, anticipation in upcoming till 2027. And you mentioned just partnership in the work requirements. And I'm just curious, technologically, we should have the ability to facilitate the determination of eligibility readily. But I'm just wondering, all of this being on OHA, but, thinking of those partnerships of health systems. And I just think in my own context, in my own clinic, we do a great deal of this and facilitating that. At the same time, being careful about information sharing nowadays. And just wondered if you could comment on, the thinking about how you mentioned this briefly about IT and leveraging that to facilitate, most of patients, there is those on the edge of eligibility, but a large majority of individuals should continue to maintain eligibility. They just need to go through the process every 6 months. And I just wonder if you could speak on that.
Yeah, happy to. I mean, I would say kind of 2 different things. One is just, kind of a reality check on where we are in the process, right? We are, since the passage of HR 1 in July, have been working to identify what those system change needs are. And they're tremendous. And that's across our shared agency services with ODHS, who is also going through the same thing for SNAP and their payment error rate changes. We share the Oregon Eligibility Partnership. And so there are just a lot of different system changes that need to take place, and we need to understand how they all fit together in this complex environment that we find ourselves in, and recognize that there were a lot of other demands already on those systems, a lot of things in the queue, and kind of tough decisions that need to be made around prioritization. A lot of those questions are about, do we prioritize this federal requirement over that one, right? There's not really a lot on the list that's optional. At this point, it's about being, again, good stewards of the resources and making those tough decisions about how do we actually meet all of the requirements with the limited time and bandwidth that we have. And speaking of bandwidth, I think that's where we really are at this point, is defining what those resource needs will be, and preparing to make requests of the legislature in the February short session. So we do need to make sure that we have the budget to move forward with these changes. These are not the types of budget requests that we like to put forward, but unfortunately they are the ones that we are preparing now. And come February, we'll have a better sense of how we can proceed. So there's a lot, I would say, going behind the scenes around that planning. But when we get to that actual system implementation, Tony, that you were mentioning, I think that is our our central goal here, again, is to keep people covered. And there are so many people, 500,000 people that are going to have to go through these systems and have to go through additional administrative checks that aren't in place now that are eligible for Medicaid. They're going to have to do all of those things and jump through those hoops just to prove that they are, at the end of the day, eligible for the program that they're trying to get access to. And they're going to have to do it every 6 months. And so our goal is to make that as easy as possible. There are things that are not going to be options. There are things that we are not going to have flexibility. And I can't promise or overstate that we'll be able to minimize all of those. But that is absolutely what we are going into this, like, clear-eyed and focused on, and look forward to hearing more and continue to engage with folks on the ground like yourself who can help us understand how to make those systems work for that, to meet that central goal.
Thanks, Claire. And just in that commentary that, I think the board, we want to be supportive in thinking of, what kind of influence and advocacy we can have as far as needing to be legislative. We've talked as a board, just, where we can help shape that support, and just offer that up.
In our couple remaining minutes, Brenda with our last question or comment.
Thanks. And this can be kind of turfed, Claire, to next month's board meeting if you prefer. Earlier today, we had a public testimony about the Quality Incentive Program, and I know that's been a hot topic for this group and brought up at our board meeting and our retreat last month. So one thing to request, I guess, is as you and the board leadership think about how to frame that conversation, how to reply to the interests and the conversations that have been emerging. One thing that's on my mind is obviously any updates that you can share about our current thinking, how we sustain quality in the midst of the budget constraints that we're facing. And then second, to consider, what is retroactive, where people have been doing a lot of quality payment work over 2025 and have built budgets around that kind of work, et cetera, have delivered really significant results. And what is prospective, what we're anticipating shifts and changes to the future programs may look like, just considering the times that we're in. So mostly just wanting to share and see if I can be of any support to help shaping those conversations as we think about them moving forward. Be happy to lean in if that's useful. And I'll turn the time back to you, Kirsten. Thanks.
Thank you, Brenda. Claire, go ahead.
If there is time to respond, I can at least respond quickly. And then I do think this would be a great conversation for continued discussion. And so I think just to, again, level set, the Quality Incentive Program financial incentives are bonuses in additional to those monthly rates that OHA pays the CCOs. And the current 2026 CCO rates create a general fund need. And the bonus pool is an option that has been used in the past to balance state funds. And in addition to balancing the current general fund need, there's just a recognition and mindfulness around the other changes at the federal level that are changing our healthcare landscape. So this is a tough situation, and our highest priority is to keep OHP members covered while balancing that budget and being a good steward of taxpayer dollars. There has been no decision on the quality incentive pool payments. OHA will make a recommendation to the legislature, and it will ultimately be the legislature's decision in the short session about what happens to those quality incentive pool payments. We expect to share more information by the end of this month about the recommendation that OHA will put forward to the legislature to continue consideration of how, again, to balance the budget.
Thank you, Claire. Tony.
Make it brief. Thank you, Claire. I really appreciate the budget constraints we're finding and trying to figure out how to navigate the waters of what we have available as a state. I just do need to clarify that I know we think of these as bonus dollars, but a lot of health systems don't think of them in that light. And I think we should be clear on, as Brenda mentions, the investment that's taken place over, a year of 2025. And I would just encourage us to be clear on dates as best we can. I know we're submitting this to the legislature, and that will be the decision making. But as future planning, and I think I've mentioned on other calls that, this is staffing. This is whether somebody has behavioral health in their clinic. This is whether somebody changes their hemoglobin A1Cs and their breast cancer rates in a clinic. And we have invested so much in value-based care, and that's kind of how we're putting our chips. So I understand the constraints we're at, but I would argue that a lot of health systems do not see these as bonuses. It's actually the work being done.
Okay. Thank you. Thank you, Claire, for joining us. Tony and Bill, about to turn it back to you guys next. In last month's retreat, OHP board members Bill Kramer and Tony German have been working on guiding principles to support the new affordability committee, which supports OHPB's affordability priority. So they've been busy at work and have updates for us. So Tony, Bill, take it away.
Great. Thank you, Kirsten. Yeah, we're hoping to switch gears into the Affordability Committee. At our retreat, we had a discussion regarding what does affordability mean? And it's such a broad scope and a definition, and our Committee on Affordability has kicked off. And the Industrial Advisory Committee also has started its work. And I think we're really thrilled by the discussions that have been initiated and trying to help coalesce around strategy in those spaces to develop productive policy recommendations that will come forward to the Oregon Health Policy Board. We thought it would be productive to help give some guiding principles. And I know we talked to some of these themes at the retreat, and Bill and I had the opportunity to just kind of put some things on paper and share that out with the group. At the last Committee on Affordability, the committee was able to look at some definitions of what that means. And there are a number of really remarkable pieces of work that are taking place in multiple states, and led by the leadership of Sarah Bartleman and staff helping the Committee on Affordability. I think they're starting to define some of that. But hoping to put in front of the board here some ideas that we would hope support the work on the Committee on Affordability. And maybe we can just jump into that, Tara. So looking at just some overall values and principles, I think in our discussions and development of the program, really trying to keep this centered on the patient experience and the consumer experience, and really prioritizing real world financial impacts on them. So we felt that that was a really core principle. We also had a discussion about public good and prioritizing initiatives where in the aggregate, it's going to benefit us as a society, as a community, and that of Oregon. And some examples we thought shared increased access to care, reductions in emergency care, improving chronic health outcomes for individuals, and in the context of the healthcare system, improving workplace productivity, but not really having a disproportionate burden on particular stakeholders in organizations. So, I know that these are broad, but really kind of looking at the overall aggregate good that we're trying to accomplish with these policy development. And then equity has always been centered for us, and really focusing and selecting policies that focus on improving the burdens of cost, those that are in marginalized communities or lower income groups, and those that are in areas of the state in our rural as well as urban centers. So focusing on that. Then I'll go to the next slide. I think Bill is going to continue on.
Thanks, Tony. Next slide. Okay. The three additional values and principles that we're proposing to help give guidelines to the Affordability Committee. First, this next one is that the purchaser perspective should also be prioritized. This is small employers, large employers, and the state as a purchaser, making sure that the whatever is brought forward helps to improve affordability for those who purchase health benefits on behalf of their employees or beneficiaries. We also think it's important to have evidence-based decision-making, wherever possible, to favor policies where there's good reason to believe that these will result in real cost savings. And this last one, in terms of simplicity, administrative efficiency, I think just about every diagnosis of the affordability crisis in Oregon and the United States points to administrative complexity. And while this starts to get into some actual solutions, we thought it was important to highlight this since it comes up over and over again and could and probably should be an area for policy change or policy improvement to favor policies that would reduce administrative complexity. Let me turn it back to Tony for two final kind of broader guidelines.
So helping them in some direction, looking again at our systemic solutions and focusing on seeking change to healthcare and how it's delivered in finance. And not only as a lot of solutions and a lot of policies have been more focused in the space of potential subsidies, but thinking again in the more comprehensive reforms and thinking of how that could be transformative for individuals and their total spending. And then we thought it was important to emphasize that, we do want to see some short-term goals, but we also really want to think long-term and having those both included in the selection process as they lead into their work. So this is really just a start in the conversation. Really wanted to open it up to the group. If there's anything missed or anything that should be included, welcome conversation here. This is really just a starting point to really think to focus in on a core set of values and principles, I think, and help them in this process. Again, really excited about the creativity that's taking place at the Affordability Committee, a number of policies and looking across a number of the states and feel that there's great value in what OHA is helping support this body of work. But yeah, I wanted to leave it as an open conversation. Did we hit the mark on these? Are there things we should change or anything we should add on?
Great. Thank you, Bill. Thank you, Tony. Putting pen to paper isn't always easy. So Brenda, go ahead.
Yeah, so true, Kirsten, especially in the context of such a complex conversation. So I appreciate the work Bill, Tony, and the team have done to prepare for today. I'm thinking a little bit about where you might go next. I like the open-endedness of the frame that both of you have offered for the committee in terms of setting just kind of intention or setting general guidance. And I'm curious if there's something that this board may evolve to that's a little bit more pointed, a little bit more directive, that'll support the committee in coming back with recommendations or perhaps more specific policy to remove barriers that they faced in the past. And so this is, as I appreciated Tony and Bill, your framing is like, this is an opener, this is a conversation to set guidance, kind of narrow in a little bit. And I'm curious how ambitious we're thinking we might want to be about setting more deliberate direction. So I don't know, it just came to me. Talk to me, what are you thinking?
Well, I'll give an initial reaction. I really appreciate you raising that. I think this will be an evolving, maybe iterative process as the Affordability Committee kind of starts to gain traction or use another metaphor, sink its teeth into this problem and begin to develop some solutions or at least recommendations for how to address the crisis. I will say one, you asked about how ambitious we should be. One is I think we will be probably as a result of those conversations, sharpening or maybe adding to the guidance from the board. So we don't have to wait until next spring to react to what's happening in the Affordability Committee. We don't have to wait until next spring to come up with some refined or additional guidelines. So if there are any thoughts now or next month or the next month after that about what kind of guidance we should be giving to the committee, please let us know. And Tony and I will continue to think about that and collect ideas. I will say one broader, you used the term ambitious. How ambitious should we be? While it's not written here explicitly, I think both Tony and I, in our comments or verbal interaction during those initial meetings of the committees, encourage them to be bold. There have been a lot of efforts over the years to address the affordability crisis. Some of them are modest incremental things. Some of them have been somewhat bold. And we're just seeing that the continuation of the crisis, the lack of progress on making healthcare more affordable, says to us that we need bold and bolder recommendations. So we, in a sense, kind of giving them license to be bold and not tiptoe around this issue, and really try to come up with some significant improvements, solutions, recommendations that would result in significant improvements in affordability.
Hayden, go ahead. Or Tony, sorry, did you want to respond to that?
No, actually, I was just going to ask Hayden.
Great. Yeah, thanks, Tony and Bill, for this work. My question is just whether you're able to provide a bit of flavor on some of the policies that have been discussed, or Tony, you mentioned there's been some learning from other states. Is it possible to fill the committee in or the board in on any of those, or are those discussions, would that be a bit premature now?
No, I'd be happy to share just a flavor. There is a whole list of, I think, ideas that are floating. And I think right now it's really helping them design a bit of a rubric for them to elevate one policy over the other. There's a broad swath of, I think, policies that have taken shape over several years. And as Bill has mentioned, some of those have hit barriers and walls to proceed forward. And oftentimes that's politics, right? And I think we're hoping to find that, Pareto optimal move to move policy forward that's going to be broadly improving total spending for a family and individual across the state. And improve healthcare without having a tremendous impact on other stakeholders. Just some flavors, and I'm sure not to draw Claire into this, but Bill can add some too. But some of those are considerations of looking at past policies of the cost growth target. Some of them might be the facility fees or site neutral payments that individuals might be looking at. That's looking at potential for bulk purchasing for pharmaceuticals. Looking at considerations of price caps, right? And some space there to think about where that has value and to slow the growth of healthcare spending with that. So those are some there's maybe some specifics, but some other larger topics that have come forward. And Bill, do you have others that you might elevate?
Well, I was just going to respond to a question by can just a very brief recap of what the nature of the discussion was at the most recent Affordability Committee meeting. There was a good discussion about affordability for whom. It's consumers and households, employers and purchasers, the state, healthcare providers, health plans and insurers. And based on the discussions we've had at the board and guidance from Tony and myself, we reiterated that we'd like the committee to focus on affordability for consumers and households, employers and purchasers, and the state. And then there was a good discussion about how to measure that. There are a variety of measures. Didn't land on any specific ones, but there's a good, lively discussion, and the staff will continue to work on a number of measures of those for consumers, purchasers, and the state. Then there was this follow-up. The second part of the meeting was about criteria for developing policy recommendations. And while there wasn't an evaluation or a deep discussion of specific recommendations, there was in the discussion of the criteria, there was an example used from the state of Washington and several others about what criteria would be applied and then how various policy options would fall. So, for example, in Washington State, there was consumer and the impact on consumer and purchaser cost projections, transparency tools, different types of measures. Different types of recommendations, and see what the impact would be on cost and the level of complexity. So there was several slides that talked about a whole range of policy options, going from limiting facility fees, balanced billing protections, hospital price transparency, up through administrative simplification, oversight of mergers and acquisitions, all the way up to reference-based pricing, provider rate setting, and global budgeting. There was, again, no discussion of those specific recommendations. They were given as examples of how these other states have applied criteria. So I know the group will be diving into those, but I would say at this point, there's a full range of options on the table, and that'll be the next phase of the work for the committee.
Okay. Thank you, Bill. Any questions or comments from other board members? Okay. How are people feeling about these draft principles? Because I think this work is the committee has been tasked with doing this work and diving into it fairly quickly, right? With recommendations coming back this summer. And so I think that Bill, I think you said it, that like this can continue to evolve, and it's not like oh, you had your chance to say something and now we're done like that. But they will do their work most efficiently the more guidance that is provided, as we want to prevent them from boiling the ocean here. So Brenda, go ahead.
Thank you so much. And I'm thinking this document will make its way so we can reflect on it some more and then provide feedback at another time too. But my reflections just out of the gate are good job. To me, what I really appreciated hearing in this was I see our health equity definition kind of strung throughout, both explicitly named, and then also the orientation built to your 3 kind of target audiences about consumers being first. And when I think about all of the landscape environmental changes that HR 1 and what the state is currently facing, that keeping our intention right there around our health equity definition and consumer advocacy from a standpoint of affordability is the path forward from my perspective, the one that's going to resonate most with most people. So I wanted to thank you all for your vision and for staying the course on this. It's really powerful work. Thank you.
Well, thank you very much, Brenda. As far as, proceeding, I think this will be an ongoing evaluation on how we kind of continue to support the work on the community affordability. We thought that this was a good starting point. If I could be bold to see if we wanted to proceed with taking just a vote on these principles and values in this direction. If anybody wants to make a motion, proceed with a vote on that.
I so move. Thank you for the invitation.
This is Melina, I'll second.
I'm happy to say.
Sorry.
Thank you for the motion, Brenda, and the second, Melina.
All right. Well, we'll proceed with just a vote for everybody.
Okay, great. I'll do the roll call for that. Dr. Hemmings,
Yes.
Brenda Johnson,
Yes.
Kirsten Isaacson,
Yes.
Bill Kramer,
Yes.
Hayden Rookley,
Yes.
Peter Starkey,
Yes.
Melina Moran,
Yes.
Tony German.
Yes.
Great. We have 8 of 8 voting members approving the guiding principles.
Thank you very much, everybody. Pass it back over to you, Kristen.
Thank you, Tony and Bill, for your efforts. So following next will be another member group that's been working hard behind the scenes, Brenda Johnson and Melina Moran. Brenda and Melina shared their draft primary care policy proposal at the retreat last month and are sharing progress updates with us today. It's taken tremendous leadership here, and thank you for your heart and dedication that both of you have really poured into this. Begin whenever you're ready.
Thank you so much, Kirsten. It is really a pleasure actually to be joined by Melina and Krista Mars, and I'm thinking Summer and Amy and Alyssa, and a lot of support from OHA leadership to get us where we are today. I don't have a formal request of the board, but mostly our intention is to give you an update on the work that we've been doing since our retreat, and then to bring forward a formal request to the board at our December meeting. So for those that might be newer on the call or didn't attend the retreat, we did spend a big body of work orienting and prioritizing the board's work for the next foreseeable future into the work of primary care. The amount of support, I think, is really echoed both by all of the board conversations we've had, but certainly felt in pretty strong alignment with OHA around work that they had already been thinking about doing and had certainly been supporting in primary care for some time. And I think the momentum is really exciting, frankly. That's my current personal experience. And so what I appreciate and want to change or share with you all today is a bit about kind of the scope and what to anticipate to bring, or that we hope to bring to you at the December meeting, and then to gain any feedback. So our first and next body of work is, as we outlined in the board strategic planning retreat, is a bit of a primary care policy integration committee charge. We originally wondered whether or not we were going to be able to move forward with that design, and we think that there's a path forward where we can have both OHA support and engaging a lot of people that are currently invested in this conversation to align our intentions more strategically with the work that has happened in the past with the Primary Care Payment Reform Collaborative, Healthcare Workforce Committee, and other committees of the board. We, I think, are actually looking hard at developing a charter for us to bring forward for December, and to be establishing a committee membership relatively quickly, going through a traditional committee application process, which is a pretty open and robust process to be able to invite members of or individuals who are interested in this body of work. And we'll seek members who are leaders and decision makers in their organization, represent multiple perspectives of providers, of payers, advocates, perhaps legislators to the committee. The individuals who are committed to collaborating to identify action and actionable solutions that will really advance the primary care system forward faster. And so we're excited to give you an update. We'll give you much more details at our next meeting. Melina, I'll turn to you to see if there's anything in particular I missed, or then maybe open to questions from the board.
Yeah, no, thanks, Brenda. I think you pretty much covered it. I just, yeah, I'm really excited about this and aligning all the work that's being done throughout the state in primary care. It's much needed. And it seems like every meeting I hear more and more pockets that primary care is being done in. So to bring that all together is just so important. I think the application process is going to be quite competitive. I think a lot of people are going to want to sit at this table. So that's exciting also. But yeah, thank you, Brenda. I think you gave a great overview, and yeah, open to questions.
Any questions by board members? Primary care.
Well, that
Peter
was
wants to be called on, I can tell. Just kidding. Sorry. Tony, go ahead, and then Brenda.
Yeah, just a big thank you, to your leadership and attention to this. I know it's been a focus in bringing it to the board. Really appreciate the investigation. I know there's been had to change the direction of this body of work, and as far as support for it and the funding, and I think your persistence, your perseverance on it, I really appreciate. And I look forward to the December meeting. I think I shared my comments at our retreat. Some of the difficulties, as we've mentioned, is the siloed nature of the work and what we pay attention to primary care, and that the difficulty has not been a comprehensive and a more expansive look of all the things that go into primary care. As evidenced today, we were just talking about how behavioral health has been put in our behavioral health committee, and attention to that. And that is a large space of where we're looking at our team membership. So I really look forward to that, and ensuring that we are looking at the forest and not at the trees when we dive into this priority.
Yeah, thanks, Tony.
One thing that I've just really observed in the work of Brenda and Melina with OHA staff is there's been a tremendous amount of flexibility and creativity, which I think is essential as we work at how do we move forward big picture priorities that need attention in this moment of constrained budget and crises. And so I just really appreciate the creativity and dedication that has been poured into this priority and finding its path forward. And I'm excited for the presentation next month. Oh, Brenda, you were starting to speak before. I don't know if you want to add any more.
No, just feeling really grateful. And I'm so glad you echoed that back, Kirsten. The challenges that OHA are facing are so significant. To stand out on this being a priority, and for the board to know how critical it is, because the crush around primary care is so pervasive right now. And it's not that it hasn't been for some time. So I just really appreciate the courage it actually takes to put a shoulder in and lean in hard, because that's what it's going to take. We're going to find many obstacles along the way. This committee is setting itself up for a lot of heavy lifting. And so this board's support of its committees, I think, is going to be incredibly powerful and important to carry it forward. So I appreciate the intention, and it's really delightful work to do because so many people have shared vision about what might be possible. It's about aligning it. And that's the fun part. So thanks for the time on it. And I look forward to next month's presentation as well. Thanks.
Wonderful. Well, I'll keep an eye out. If any hands go up or board members come off mute, feel free. Otherwise, we look forward to next month, Brenda and Melina, and thank you for all that you've invested in your leadership here, and for your OHA partners. And actually, it's more than OHA partners. You have many shoulders leaning in, and so appreciation to those. And with that, I think we will close our updates about our priority areas. And we will adjourn our meeting a little bit early today. Gift of time to everyone. On our next Oregon Health Policy Board meeting will be December 9th. And that is a hybrid meeting with the option for members and meeting attendees to join in person at the Portland State Office Building, I look forward to seeing everyone there, either in person or on the screen. And until then, take care, everyone. Bye.